It's a very difficult moment to replace Raul. However, at least the Brazilian accent, you will have it. So, just could you please explain how it works? Forward. So for this presentation, I have no disclosure to declare. We are going to share with you a case of a 13-year-old boy that presented last December a deep intraparenchymal hemorrhage. As we can see by the MRI that was performed in April, it was located in the left optic radiation. Fortunately, the patient had no neurological deficit. The initial angiogram has disclosed a deeply located brain AVM whose main arterial feeder was the anterior choroidal artery with two main draining veins that reached the galenic system. According to our classification, it was a Spetl-Martin 3, and we made a multidisciplinary decision. In our general practice, we use pre-embolization followed by surgery, but in this specific case, the neurosurgical team withdrew the treatment and asked us to perform embolization alone. For that, we had two plans. Plan A was to perform the traditional arterial embolization through the anterior choroidal artery, and in case of failure, our plan B was a transvenous approach for retrograde obliteration of the AVM. In order to achieve this goal, our tactics was to use a marathon with hybrid 0.008 followed by injection of onyx through the arterial choroidal artery. It was not difficult to catheterize the proximal part of the anterior choroidal artery. However, when we tried to further navigate distally in the anterior choroidal artery, we have a herniation of the micro, and we could not progress. The reasons for the failure was naturally the stiffness of the marathon, and I did not have a magic at that time, and I did not have neither a complete balloon to use as a support for the further progression in the choroidal artery. That in some instance, Rafael, I used to use this kind of setup, the complete balloon, to allow a further progression in the lenticular striate artery. Since we have a failure, we had already, as a good fight pilot, the plan B, that was a transvenous approach. For that, the step one was a direct jugular punction with a short 6 French sheath that was then progressed in the lateral sigmoid sinus. Why I did not use the right jugular vein that was more developed? Because in this specific case, the striate sinus drained in the left lateral sigmoid sinus. So we had to punction the more hypoplastic one. When we placed the long sheet in the left sigmoid sinus, we then progress 5 French vertebral catheter in the straight sinus, and through it, we navigate an Apollo with a hybrid in the main draining vein. It was a lateral, inferior atrial vein that was not difficult. I work very fast, as you can see. Then I ship a marathon over the Apollo in the main draining vein in order to perform the reverse pressure cook technique. For that, we start injecting the onyx through the distal Apollo. Once we have the retrograde reflow of onyx over the Apollo, we stop and wait a little bit, and then we inject through the marathon the NBCA, the glue, in 70% concentration. 2 cc of NBCA plus half cc of lipiodol, as you call in Brazil. I don't know how do you call it in English. How do you say? Okay, thank you. So that was the goal, to perform a proximal occlusion of the vein in order to allow the further progression of the onyx. Once we have done this, our goal was achieved. Then we start the injection of the onyx, and as we can see, the video is not fast. The retrograde progression of the onyx is very fast, and we could achieve with just one injection the obliteration of about 90% of the AVM. Once we have done this, I call this the kamikaze technique, we cannot stop. So we double check if there was any residual needles in the anterior choroidal artery. As we can see, there was a small amount of needle in the inferior portion of the AVM. Then we proceed further injection of onyx, and we could obliterate completely the AVM in one session after 2 hours of procedure. This is the control. The final angiogram. This is the patient the day after. I cannot, as you know, even with the child, if there is a legal authorization, we cannot show the face of the patients. So just the day after, and he was discharged after 3 days to home. Thank you for your attention.